The following is a presentation of the Healthcare Facilities Network.
Hello, and welcome to the Healthcare Facilities Network. I am your host, Peter Martin, president of Gosselin Martin Associates. As always, thank you for clicking on this particular episode. Today's episode is a different one for the Healthcare Facilities Network. I hope it's one that you enjoy. Today, we are going to look at healthcare facilities management finances. It's the first episode we've done about finances, and I've enlisted two great guests to help me in this endeavor. First guest is Robert Hacker, and I'm going to ask them to introduce themselves in a bit, but we have Robert Hacker. He's a director of facilities management, and we have Jim Corwin. Jim is the CFO. So Robert and Jim work together. And gentlemen, Robert, let's go to you first. Where do you work together? Tell us your title, tell us who you are, and where do you work?
My name is Robert Hacker. I'm the facilities director for a small 2-hospital system out here in Southern California. Community Healthcare, I believe, is our new title now. Community Memorial Health System was our old title. But I'm responsible for a 2-hospital system and about 23 clinics or so. Typical facilities management scapegoat for everything.
And Robert, you are located, one of your facilities is in Ventura and the other in Ojai?
Correct.
Excellent, excellent. And you may recognize Robert from our intern episode that we did. This is Robert's fourth time, right?
I think this will be number 5 total.
5
previous.
He's got the early lead for
yes,
on the Healthcare Facilities Network. Robert, thank you. Jim.
Hey, Peter, thanks for having me. So my name's Jim Corwin. I'm the Chief Financial Officer for, as Robert said, it used to be Community Memorial Health System. We are now Community Memorial Health Care, and healthcare is one word there. We're trying a new branding strategy there. So I've been I was a professional musician actually for about 5 or 6 years. And then I got into healthcare finance, which I just fell in love with. And I've been a CFO since 1997.
Okay.
So I'm in my 26th year of being a CFO. I was with Tenet for 12 years, and for 5 of those as a CFO. And then I was the regional CFO for the state of California for Providence Health Systems, which is sort of a Seattle-based company. Okay. I was in charge of their hospital division for a while, and then they developed a physician division, and they didn't have a leader. So they asked me very nicely, your job's at stake if you don't take it, but a few bucks, and a few minutes later, they put me over a physician division. So from 2008 to 2020, I ran their physician division, it grew from 300 doctors to 900 physicians. We had 120 clinics, and I was running about $750 million through there of net revenue, which is not dissimilar to our size. Robert said it beautifully. We have 2 acute care hospitals. I see us as a 3-hospital system just because we have a SNF, and the skilled nursing facility is 75 beds. It's robust. It has a lot of care and need. Reimbursements just gone berserk in the SNF area. It's made it more difficult. So Robert really has 3 facilities. We're very lucky that 2 of them are fairly new. So that means we don't have that huge central plant exposure, but our Ojai acute care hospital is in bad shape. So I joined here 4 years ago, and I'm just starting my 4th year. I started in August of 2020, and I just love being in a standalone. I always worked for health systems, Peter. So I was always about executing what they asked me to do. This is kind of fun because Robert and I get to actually make the decisions. I just wish we had more money. That's the only constraint Robert and I have. So it's perfect topic for you today, Peter, because that is our single biggest challenge is the ability to afford what needs to be done.
Well, that's actually where I want to start, Jim, is money and kind of talking about perhaps some of the challenges of today that are a little unique. I'd imagine money is tighter than ever. But before you answer that, so you said you were a musician. Were you a full-time musician prior
I
to,
was a full-time musician
what did you play?
from 1979 to 1984. I was a bass player. I come from a family of musicians. So my father was Peggy Lee's band leader for many years.
Oh, wow.
And my grandfather was a songwriter named Johnny Mercer. So Johnny Mercer founded Capitol Records. He wrote Moon River, Hooray for Hollywood.
As I say, I think I've heard that name Johnny Mercer before.
Yeah, he's pretty well known. So
Yeah.
I still, manage his publishing catalog. So,
Wow.
but Robert doesn't give me much time to do that. Me and him are focused on the hospital.
I thought this was the Health Facilities Network.
Well, it is, but that's why I love talking to people, is because you find that's really unique. And so it is the Healthcare Facilities Network, and you made a transition so did you make the transition into finance out of the band? How does that happen?
Yeah, I hurt my back and moving equipment, and realized my grandfather set aside some money for college. And so I figured I'm just going to take advantage of it. Moved around a couple of industries and then found healthcare in 1990. And I met a healthcare CFO. He says, if you get good at healthcare, you will always be employed. And that people are always going to need healthcare, and it's only going to get worse. It's not going to get better, in the sense that people are going to get older and need more care. So if you want security, get good at healthcare, you will have a job.
He was right.
Yeah.
I think, with all the difficulties the market faces today, there's still a lot of truth in that statement. So talk about today, Jim and Robert. Obviously, we'll kick it over to you. I know you're probably chomping at the bit, but Jim, can you talk a little bit about the current market, current state of healthcare, the availability of capital, the tightness of dollars? How do you assess today?
Well, what I'm just has been the saddest development over the last 15 years, Peter, is nobody wants to pay for healthcare. Everybody wants it, and they want it to be very good, but nobody wants to pony up the cash for it. We're unique in the senses we have forces. I saw a great speaker one time said the most successful healthcare systems in countries are where they just have one system. So forget universal care, forget anything. They have one system. In Switzerland, it's privatized. We have four systems. We have Medicare, Medicaid, private insurance, and no insurance. So one of our four quadrants of coverage is nothing. And that segment is growing. California has, participated in managed care 30 years ago, thinking that the whole world's going to go to managed care, and the rest of the country said no thanks. And so California is unique in the sense that they've accepted lower payments. Medicare has been ratcheting down their payment. I call them Medi-Cal on steroids now. And so in the old days, if you were 50, 60% Medicare, you could make some real money. And remember, we're not for profit, Peter. So our whole goal is to generate, we're not for profit, but not for money. But we need the money to reinvest. And really our reinvestment's pretty clear. New services, reinvest in people, but reinvest in our infrastructure. And that's the saddest part, because when people had money, they didn't invest in the infrastructure. That was the time to do it, because, oh my gosh, I can't. Every time I've ever taken over a hospital, you needed $20 million just to get the central plant where you needed, just the central plant. And $20 million of central plant improvement gets you nothing relative to care. It saves you a ton of money on maintenance and repairs and stuff, but you really want your money to go into patient care. So, I'm really dying to see what Robert does, he's got 2 of 3 new facilities. We've got to do something with our acute care in Ojai. But, I think the secret is, at least from a central plant perspective, is going to maintain it, because he does have 2 relatively new structures that few people have the luxury of. Although with the AB 1953, the earthquake seismic requirements, Peter, a lot of people have built some newer infrastructures, but we're now these hybrid facilities of new and old, and the old is very old.
So you talked about the 4, the 4 different systems that we have. Just last comment, kind of big picture relative to the tightness of dollars and the ability to get capital. And this is even outside of your system, just kind of globally. Have you seen a market such as exists today in your experience in healthcare?
No, this is the worst I've seen it. I'd really like to hear Robert's thoughts. Let me give you another minute, but I've never seen anything like where we're at now, because the dollar need is bigger. These elevators. Hospitals have so many elevators. Just the elevators, you're talking millions and millions and millions of dollars, and that's not even done basic stuff. So I don't even know how Robert has kept our facility running in the current state, because we still have an old tower. We're maintaining it, less direct acute care, but we're still running a lot of clinical services out of there. And we've got a real worn down infrastructure in Ojai. And I'm amazed, Robert. I mean, literally, and we give them a shoestring budget. So, I pose the question, how do you do it?
This is Peter Martin. If you or your organization is interested in advertising or partnering with the Healthcare Facilities Network, including sponsoring content, then please email me using the barcode in the lower right of your screen. From the trades level to the vice president level, from planning, design, construction, project management, compliance, safety, and security, the Healthcare Facilities Network reaches FM people where FM people are. Robert?
Duct tape and bubble gum.
It really is.
Yeah.
No, it forces us to really and truly make decisions that we don't want to make. And what I mean by that is, sometimes we're going to defer certain things off. We may employ other maintenance strategies. A lot of my peers will talk about, some of the more trendy topics. Reliability centered maintenance has come into play in the last 10 years or so. But sometimes we're employing run to failure, and a lot of people don't like that. But guess what? We may have to let things go, and we'll let it go well past its life cycle. And that kind of catches up to us later on. As Jim was saying, and he kept pointing out the positive that we have 2 newer facilities. I'd like to say we have 2 very old facilities. One facility that both Jim and I are sitting in right now, a very old facility, and then we have a very old critical access hospital up in Ojai. The newer facilities, I'm not worried about as much. Obviously, newer facilities have their own issues. The first few years, they're higher cost than once they start, they're getting onto that level curve. But it's hard sometimes to make decisions, and then people don't like the decisions afterwards. Well, what can you do to prevent that from occurring in the future? Well, guess what? We can't always prevent failures from occurring. So, when we talk about finances, one of the things that I talk with Jim all the time about is, how do we get paid? And he was talking about like the 4 different basic payers that we have, or different categories. But, Jim, you and I have talked about, what is capitation? What does that really mean? When we have a capitated market, you have X amount of people that we're taking full risk on. What does that actually mean?
Yeah, that is actually my expertise, both Robert and Peter. When I was with Providence, I had 200,000 and capitated lives. Well, what's happening is the insurance companies are trying to partner, especially in California, also Minnesota, Texas, a little bit, but they need a partner to share the risk with. So what they did a lot of in the mid 90s, and still try to do, but it's thinned out a little bit, is they want a risk partner. So what they'll do is they'll go to health systems like us and go, first, you're rare because you're a fully integrated health system. You have joint ventures, you have clinics, you have not only 3 entities, one of them is skilled nursing, which is very vital in moving acute care through the system. But what they do then is they give us a portion of the premium. So what we've got to do right now, we haven't dabbled as much as I'm used to into the overall, so they share the premium with us. Well, what do? Right now, we take a primary care cap in our clinics, which means they give us, say, $25 per person, and they just give us lump sum payments, and they say, here's your quality goals, take care of everybody. And they kind of wash their hands a little bit of it. They monitor it, but we're getting the premium. When I was with Providence, we took full risk, which means we would take risk in the hospital, and I take full risk on the professional services with my doctor group because I had all the multi-specialty. So I could take a lot of the premium dollar. So, a typical rate for commercial might be $80, $90 a person. For seniors, it might be $400 to $500, even more per person. But remember, you get $400 or $500 a month times 12, so you get $6,000 to take care of this one person. You better keep them healthy. The one advantage of capitation, if you do it right, is people will stay healthy. In the late 80s, they were doing it, and doctors were keeping the money and denying care, and it blew up in their face. When we retooled everything in the mid 90s, early 2000s, and really developed high quality wellness programs. And so I would invest to even send people to the homes, and I would use that premium dollar to do that. And you find out there's a lot of extra money left if you do that, because high-end hospital care is built into that premium. If you keep it out of the hospital, you can really do well, but it's a very it's a large and exotic infrastructure, and need to know how to manage it. So I'm preparing us to be able to do that in the next 3 to 5 years. What does that mean? I'm beefing up my case management area, those types of things, to be prepared to take capitation. But we're really not designed in Ventura as not a big managed care market yet. But for us to compete, we're going to have to do that. And we have a wide enough services that we can take some risk once we know what we're doing, Peter. And so we're not there yet. So I'm not going to take that risk because it would blow up in our face. But it can really work well, but you gotta be a good person in some ways with capitation.
Sure.
But Jim, as we're looking at
I don't know if that made sense, Peter, or if it left any questions.
So how does, I liked your explanation of capitation. I like the visual of the doctor in the late 80s denying services too, because I think that tells a story. But how do those revenue streams, that impacts, you're up here dealing with those issues, and now Robert's down here on infrastructure, running the hospitals. How does a revenue stream or lack of a revenue stream impact somebody at Robert's level, keeping that hospital going? So that would be the second question. But Robert, the first one I'd like to ask, and you and I have talked about this a lot, and this is one of the reasons that I've asked you to come back on, because you speak about it very eloquently. What are some revenue streams that a hospital has that you pay attention to because it impacts your work in healthcare facilities management?
It's
like a building block, right?
Because Robert cares about everything. He's the only
Sorry.
I've ever seen that hey, Jim, we're working on this. You can suspend a bed for 6 months because you can make more on the GME money. I'm going to jump in. I want him to answer, but a couple of things he does that I've never had with an engineer. One, he understands revenue like administrators do, for one. And he actually, because he knows I'm not in the room a lot of times, because they all love to meet without the CFO. And so he becomes a true gatekeeper.
How do they meet without the CFO? You've got the money.
Yeah, but they do planning, and it's the early stages, and really they see it as we're just starting a new service or we're doing something. But Robert really acts as a gatekeeper, which I'm not used to. I'm used to engineering people just scoping it out and saying, here it is, here's the high dollar, low dollar, medium dollar thing. And sometimes they'll even start. But Robert says, I'm not doing a thing till we understand that there's an affordability index on this project. And that's, if you get anything out of this podcast, that's a true added value you can bring as a head of facilities, that you got to know, we got to figure out how to pay it. And if you're a good CFO, your answer isn't always no. It's let's figure out the option we can afford. And that's another thing Robert's amazing at, that he'll come up with a solution. He won't throw his hands up, and his answer isn't always the biggest dollar one. He'll have the right way to do it, and the next level of affordability, but it'll work better. And then here's the shoestring budget. This will just keep it going for 3 more years. So Robert, I don't know how you do that or when you started doing that, but it's an added value that you bring to an operations that I've rarely seen.
Well, I think that's one of the reasons why we're having this podcast is there's a lot of folks out there, my peers, that don't have the financial background that I do. And you were talking about it a little bit about the different types of payers that we have, whether it be Medicare, Medi-Cal, private insurance, or, some of the what I would call the Obamacare plans, or the indigent population. I pay very much attention to what that payer mix is, because all of a sudden, if we're starting to get more Medicare patients, typically we're getting older folks, and there's an effect that it's going to have on me. Typically, I don't care what the temperature is inside the patient room, they're too cold. And so we're getting these calls, it's too cold. And we're like, what are you talking about? It's 74 degrees inside the room. We also have issues with, their loved ones, maybe it's grandma or grandpa who's in the hospital. When their spouse comes to visit, we have other issues that start to develop around parking. I hate to say it this way, and I'm being very stereotypical. We have minor accidents in the parking structure. They don't necessarily always park in the parking stall itself. They take up 2 spaces, little things like that. And then, of course, if we're getting, a larger portion of Medicare, we start to have more visitors that come because we have, it's grandma or grandpa that's in the hospital, and, here's all the kids that want to come out and see grandma or grandpa. It might be their last time to see them. So there's other issues that come about. On the other side, if the payer mix starts to shift to Medicare, typically these are people who don't have a lot of money, or they have
Medi-Cal. I think you mean Medi-Cal.
Medi-Cal. Yeah. Well, I said Medicare twice. I'm sorry, Medi-Cal. Typically, we'll have other issues that start to develop. We have more vandalism. We have more theft. We have more disobedience within the hospital. And these are little things that pop up. And I have this conversation with Jim. Say, Jim, I'm seeing this. I'm starting to recognize and I'm seeing these issues developing in the hospital. And then I'll go back to him and say, hey, has our payer mix changed? And he's like, yeah, it has gone up. And I can actually tie these things together. The correlation is there. So I have to prepare for it. So as we are preparing our budgets, I come back and I say, look, if we're going in this direction, these are the things I have to worry about. a lot of times we don't even look at it. But theft of cars, cars getting broken into in our parking structure. I can actually show a correlation very quickly on how, as our payer mix has started to shift, how that volume has gone up. Those incidents have gone up higher. And so it's little things like that that we're looking at and trying to control and make sure where we're headed. Because to me, the payer mix, I'm looking at it for two reasons. Number one, I know what the income is for Jim. Okay. Obviously, he's going to want as many commercial and insured patients as we can, understanding that everybody's going after them.
Right.
But if it goes the opposite way, how do I start to tweak and prepare for those things? Understanding that there's going to be more damage, I hate to say it, to walls, to signs, to little things that can be easily taken.
Yeah. How do you track that, Robert?
I kind of watch it there's a certain sense that I can feel. It's an inherent ability that you can kind of feel. We can track it statistically. Now, I don't have a statistician on my staff, which I'd love to have to do some advanced analytics.
Yeah.
It really would be nice to come out and say, hey, but I can't afford it. And we as a system can't afford it right now.
Yeah.
So some of this we can look at, and we will track, how many assaults that take place, how many burglaries, how many thefts, and it's little things that you watch and you can actually see it. How many calls that we're getting? Are we all of a sudden getting a lot of calls in the summer that it's too cold? Well, wait a minute. Typically, it's the opposite way around. But knowing that it's going that way, I've got to prepare for it. And it's little things. Again, some of the older folks we have, one of the things y'all notice right off the bat is our handicap parking. All of a sudden, it's impacted before the other parking. And a lot of times people don't put those things together on what's actually occurring.
Well, Peter, when I was a regional state CFO for Providence, I actually got 2 finance people to support the 7 engineers that we had across our state system, because you needed that. They really need financial support, especially if they have financial savvy. So
It was funny. And Robert, I know you're an ump and you're a baseball ump. And I was thinking, as you guys were talking, these sports teams have staffs full of analytic people to say something as mundane as go for a 2-point, in football, go for a 2-point conversion if you're down 9 with 3 minutes. So yet here we are, a hospital and healthcare system that is infinitely more important than the Rams game or the Patriots game.
and more complex.
And you could take that analytics and put it to really good use, and yet you're struggling for funds. It's not a social comment. It's just kind of interesting where the focus goes. Thank you for watching this episode of the Healthcare Facilities Network.